Hello.
Yeah.
Anuradha madam, start.
Hello. A warm and hearty welcome to all on this rainy evening. I hope it's raining in Thane and Mumbai. We in the Marathwada are still yearning for the rains, but let's keep our fingers crossed for that. So a very warm welcome to today's session on otorhinolaryngology. We have I welcome Dr. Chejara, our esteemed Maha IAP President, to please give his words of welcome. Welcome you, sir.
Thank you, Anuradha madam.
Over to you.
Good evening, friends, and welcome to another session of Pictorial Pediatrics. As the title itself suggests, that we would be learning from the pictures. So when the topic came, we decided about the ENT, and I could not find better than Dr. Uppal sir for this topic, as he is master of the subject and he has done a lot of work, and he was the person who was pioneer in cochlear implant in Thane. And the good part was that I had an opportunity to work for the cochlear implant with him, because we were next door neighbor. So welcome, sir. And over to Anuradha madam. Just give the sir's brief introduction. We are already late, so we can start as early as possible. Dr. Anuradha.
Hello.
Yeah.
Yeah. Dr. Amol Pawar sir will be having.
No, he is traveling, madam. You can just introduce sir and we can start the topic.
Anuradha ma'am, are you there?
Yes, he's there.
Ma'am, kindly unmute yourself.
Yeah.
I'm unmuted, ma'am.
Yeah, we can see you. We can hear you. You can start.
Okay. So it's really a great honor to have Dr. Pradeep Uppal, a senior ENT surgeon from Thane. And as Chejara sir has already given the introduction, that he is the pioneer in cochlear implants in Thane. So it's really a great honor and a very interesting session because pediatrics and ENT is really hand in hand. I mean, it's really there is a lot to learn and lot to unlearn for everyone. So coming from a person like Dr. Pradeep Uppal, I think today's session is going to be really a very interesting session. He is a director and HOD in the Department of ENT. He is also, he's affiliated to Jupiter Hospital, Thane. He started cochlear implant program in Thane district. And also he is featured in Limca Book of Records for the same. He has presented papers in national and international journals. He's also the editor of ENT chapter in Pediatric Infectious Diseases Atlas. His areas of interest are newborn hearing loss. So I think today, without any further delay, I request Dr. Pradeep Uppal to please start the session and enlighten us and teach us and give us insights in pediatric ENT. Thank you, sir.
Before sir starts, I would add one more thing. Because of his efforts, Thane Municipal Corporation has started the pilot project of newborn screening for hearing loss. So it was all because of his efforts. And on top of it, whatever the cochlear implants are done, they are done free of cost. Means he doesn't charges a single rupee for the surgery. Even the municipal corporation bears the almost 75 to 90% of the cost, and the rest of the cost also sometime he asks the Dadar Siddhi Vinayak temple, they also gives grant to him. So most of the time these surgeries are done free of the cost, and all credit goes to Upal sir. Thank you, sir.
That's really amazing. And one more lesson and one more thing to learn from such a great person. We are really honored today, sir, to have you. We welcome you, and over to you, Dr. Pradeep Uppal, sir.
Okay, thank you. Thank you very much for kind words. I'll begin my talk, but before that, I would like to thank Maharashtra Academy of Pediatrics and all the office bearers who had given me this opportunity. Just a word of cautious, we don't have an internet here. So in case there's a problem, please call me up on a phone if we can't hear well. Just 15 minutes back, the Reliance, they send a message for 2 hours, they have some issue. Nevertheless, we'll start a session. And how do I do? First, I share a screen, right?
Yes, sir.
Can you see the screen?
Yes, sir.
Okay.
Yes.
We'll begin without wasting much time. What about this toolbar? Okay.
You can do the full screen, sir.
It's a full screen, right?
Not
This-
yet, I think. Yeah.
Okay.
Yes, sir. Yes, sir. It's full screen.
Okay.
Okay. Now, basically, I was told very clearly that we don't want any theory. We are going to talk of practical cases, what we see in our OPD. Is it moving further? Sorry, it's not moving. Resume share. What do I do?
Sir, पहले आ रहा था.
Try keys up and down keys, sir.
No, it's not coming. Just give me a second.
Or you can share once again, sir. Just close the sharing.
No. Somebody is writing on the screen. Please don't do that. I'll share again. Stop sharing and do again, Mohit.
Sir, I'll
Just
stop sharing from my side. Then you can share again.
Okay, okay.
Yes, we are sharing. Stop. You can
Yeah.
share again, sir.
Yeah. Now you're okay?
Yeah, we can see the title, sir.
Yeah, but then it's
Just try to move the screen.
Yeah.
Yes, sir. It's moving now.
okay, okay.
Yes, sir. Yes, sir. Yes,
I don't
thank
know
you.
what happened. Now, see, basically, I'm not going to talk theory. Let me have a pointer here. Okay, I'm not going to talk theory, but little bit you have to understand before I go further. I'm sorry, you all must be knowing this thing, but please bear with me. There's a pinna, the external auditory canal, tympanic membrane. There's a middle ear. From the middle ear, the eustachian tube goes in the nose. Nose means at the 9-number area in the nasopharynx. And beyond that is the inner ear. Now, whenever there is a problem with the hearing, there can be two types, either in front of this line or beyond this line. That means either in the external auditory canal or the middle ear, that is conductive deafness, or beyond that, that is a nerve deafness. We'll come to that little later on, why it is so important. Now, as a pediatrician, when you are going to see the ear, you are going to see this part. That is the tympanic membrane with an otoscope. Now, directly we'll come to the commonest presentation which we get in our clinic. A boy comes that middle of the night, starts crying with severe ear pain and upper respiratory tract infection. Frankly, this is a telephonic diagnosis. You don't even have to see the ear. If there is a history of URTI and there's a pain in the ear, that means it's an otitis media. Otitis media means what? Means the infection from the nasopharynx has traveled to the eustachian tube. Now, if you are going to see this child, if you happen to see the eardrum, you may see just little bit congestion. That is the early stage of otitis media. Eventually, this middle ear will be filled with the mucoid or a pus. And at that time, there's a severe pain. Why there's a pain? Because the drum is getting stretched. And that moment when he comes to you as a pediatrician, as a doctor, as an ENT, we tend to give some kind of ear drop, some antibiotics, decongestant, and eventually what will happen in 80% of cases, it will rupture. Whatever you do, whether you are given the medicine or you're not, 80% of time it was impending rupture, and it ruptures and the pus comes. And in my experience, they always say, oh, doctor ne drop diya, and next day the pus started coming. My point is, when they come with the severe pain and you know it is otitis media, you warn them beforehand. When we are going to give you the medicine, there is a chance that ear may rupture. Now, other important thing is this otitis media is quite normal. Normal in the sense we all, you, me, everyone, sometime or other in a childhood must have got this otitis media. That is. Now, why it happens in children? The biggest thing is the eustachian tube. That means the tube which connects the middle ear and nasopharynx is too short. And second thing is when they take feed in a lying down position, by gravity, all the milk or whatever they drink, they enter the middle ear and cause infection. Treatment-wise, I don't have to tell you, you know better, but one thing is there's a lot of debate whether to give antibiotic or no, especially a child less than a year or 2 years. Well, we in our practice, we always give amoxicillin, or if he has already taken, we add amoxicillin with clavulanic acid. Nose drop and decongestant have a big role because these are the one which will open the eustachian tube and help in draining the fluid. Ear drops, frankly, in a painful condition has no role. Why? Because the drum is intact. What will the drops do? But once the discharge starts coming, this discharge can lead to otitis externa. That means external ear can get infected. To prevent that, ear drops are very, very useful. Now, invariably, once they get infection, many of them, they keep getting this infection couple of times. They take medicine, whatever you have prescribed, or they may come to you, or they may go to family physician and take a treatment. What happens in these cases are, they are half treated. What do you mean by half treated? It means they don't get any pain, any discomfort, but they will have blocking in the ear. And these children do not complain that there's a blocking. So if, as a pediatrician, I'll request each one of you, once they get an ear pain, in a next visit, should always try to see, put an otoscope and see, can you see bubble? Can you see fluid? If it is so, then you should give some treatment, which can be any of this or all of this. In these cases, steroids have a very good role. Now, why we are giving steroid is the eustachian tube, which is congested, which is blocked, and that's why the fluid is not draining down. The moment you give steroid, short-term steroid, 2 days, 3 days, eustachian tube will open up, the fluid will drain, and patient will feel better. Now, at what stage you should think that now we should refer to ENT? If the fluid is not going, if fluid is persisting in spite of medicine, can you make out whether the fluid is there or no? If you don't have an otoscope, it's difficult, but there's a very simple test. If you do that, you can make out. And that is a simple tuning fork test. When you keep the tuning fork in front of ear in a normal condition, they will hear very well. If you keep behind, they will not hear at all. But if the child has a fluid behind the drum. That means the child had an attack of otitis media, and now there's a fluid behind the drum. In this case, in front child will not hear at all. And the moment you keep the tuning fork behind, they'll say, oh, I can hear very well. Just remember this point. We will talk a little bit about the same thing in a couple of slides later. Normal person can hear only from the front, not from behind, while patient who has a fluid in the middle ear or he has the blocking of external ear, he will hear other way around. That means he will hear from behind and not from out, not from front. This is a very important test. And the moment if you make out, oh, hearing from behind only, then that is the time you have to take an ENT opinion. And what do? We do the same thing. We confirm whether really the fluid is there. We do tympanogram, which really tells us that there is a fluid. And then what we do, we put a tubes or we put a grommet. These are called ventilating tubes. What they do is, because the eustachian tube is blocked, the air is not going in the middle ear. We put this tube so that air will go. For a layman, for the patient, sometimes we explain, oh, we are putting a tube so that your pus will drain. But no, the real reason of putting this tube is so that the middle ear can be ventilated. Remember, anywhere mucosal lining, if they are not ventilated, they are going to produce mucus. And we want middle ear to be ventilated, so we put a grommet. In fact, in US, among all the surgeries, the largest number of surgeries done in US by an ENT surgeon is putting a ventilating tube. In our country, we are still a little reluctant, pediatrician, ENT, and patient, hoping that the fluid will subside. And that is the reason we are getting all these cases. Almost every day I do one surgery. And why do I do? Because either they have a perforation or retraction or cholesteatoma. 80% of these adult patients, they come for surgery because in childhood, we have not put the grommet. If we would have put a ventilating tube in childhood, perhaps this could have been avoided. So my request is, you don't have to send every case to ENT, but if you see a fluid accumulated behind the drum and not subsiding, do consider. Very quickly, how to use an otoscope. Hold it like a pencil, let the little finger rest on the cheek so that if child moves, it's not going to hurt. Right ear, use the right hand, the left ear, use the left hand. In a little bigger children, 5 years and above, you have to pull the pinna upward and put an otoscope. You'll be able to see the eardrum fantastic, very beautifully. Now, there are few of my colleagues, very in a reasonable rate, in 4,000 or 5,000, I don't know, we get an otoscope which can be connected to the phone. So you just see the picture on the phone, just press and you can record and give it to the patient. So I believe as a pediatrician, you should have this otoscope, either manual or digital, which are very cheap nowadays. Now, once you put an otoscope in the ear, you're going to see wax. And one thing you have to remember, not only for your kids, for yourself also, the wax is only formed in the outer ear. Wax is never formed in this part. This part doesn't have a ceruminous gland. It's we people. Now, this is a normal wax in the outer part of the ear. And when we use a bud or something, we tend to push the wax deep inside. The interesting fact is the same company who makes a earbuds, abroad, in Singapore, I think I saw, it's clearly mentioned in the red line, not to be used in the ear. When I asked the company people here, they said, no, these are meant to clean the crevices of the ear. It's not meant to be put in the ear. Well, this is just for your information that birds should be discouraged and avoided. If the pediatrician would like to clean it yourself, it is very safe, very easy. We use microscope, but it's not needed. Simple syringing can be done. Important thing is use this syringe. What do you mean by this syringe? It is high volume, low pressure. That means a lot of water will go, but the pressure will be less and it will irrigate the ear canal. Only remember is, in painful condition, you should avoid. History of ear discharge you should not do, and water should be at a body temperature. Otherwise, you will do a caloric test and child may get giddiness. I'm sorry, I forgot to see the time. 1 minute. Okay. Okay. I think, okay, fine. Hydrogen peroxide should be avoided. Now, another very, this thing which I have seen is they come to you with the foreign body. Doctor, at the middle of, and invariably they will come with at the middle of night. I think this is not opening, it's okay. If there's a foreign body in the ear, don't do anything. Just put any liquid which is available, which is whether it's a fluid or preferably oily based liquid. Normally we tell never put oil based liquid, but in this case we tell you to put the oil, anything, water, whatever it is there, so that the insect will be drowned, and the next day you send to your ENT colleague to remove it. At night you send to the ENT colleague, he will be also half sleepy, he will try to remove, and there's a high chance that some kind of damage can happen to the ear, and it is never an emergency, provided the insect is suffocated. Other thing which we come as a ENT surgeon, as a you, that there is some child playing, slap injury, and there's a bleeding, or bleeding may or may not be there. And when you put an otoscope, you see the perforation. Could you appreciate the perforation? Yes. Now, what to do? Should we give antibiotic, anti-inflammatory, ear drops? No, no, and never. No ear drop should be given because it's a sterile perforation. Now, if you try to give some drop, you're going to carry the infection inside. Now, 90% provided you don't put any drop and oil. This is a case with us, had a perforation, I had an opportunity to record it, and then after 2 months, it's completely healed. Of course, 90% of them heal, 10% do require surgery, but it's never an emergency. You remember I told you about the tuning fork test? All the problem up to the line, patient will not be able to hear from the front, he'll be here from behind. As a pediatrician, as a doctor, as any member of society, can they make out where is the problem? It's a very simple test I'm going to tell you. Please, if you're doing something, pay attention here for a second. Any problem in front of the ear, it is treatable. If there is an inner ear involvement, it's a semi-emergency. It's an emergency. We have to see the ENT immediately so that something can be done. But as a pediatrician, how do you know that this is an emergency or this is not an emergency? Very simple test called humming test. Very simple test called humming test. I request all of you, just do this. Wherever you are, clench your teeth, close your lips and do humming. And put one finger in one of the canal. And what you will realize is, if there's a block in the external ear, or if there's otitis media, if the child is doing humming, or if you are doing humming, you will hear in a deaf ear. But if the inner ear is involved, and you do humming, it will be in the normal ear. Understood what I said? I hope so. This humming, if you don't listen to anything, just understand this humming test for a day. I feel my lecture was worth it. You should tell the parents, if during humming, child says that I can hear in the side which the ear is blocked, no urgency, treat as much as you want. But if he says, I'm hearing in the other ear, it's an emergency. You must have read a lot about Alka Yagnik case, and I don't know really what happened, but what I realized is she went quite late to the doctor. She had a nerve deafness, inner ear problem, viral, and nothing great. Every week we see one patient, but because she's a celebrity, it was hyped a lot. But the fact is that take this opportunity and understand that any patient who says I've got decreased hearing, child or an adult, do a humming test. If they can hear on the same side where they feel my ears are blocked, no hurry. But if they hear the humming on the normal side, it's an emergency, visit the doctor. Quickly, in next 5 minutes, I'll speak about a cochlear implant program. First of all, you have to understand that cochlear implant is different than a hearing aid. Hearing aid, what it does, whatever little bit residual hearing is there, it amplifies that sound so that it reaches the brain properly. But cochlear implant is totally, cochlea is dead, and we use the electrical signal. There's a normal ear, everybody knows how the sound enters the ear, ossicle chain moves. The heart of the ear is cochlea. It's a transducer which converts the mechanical energy into electrical impulse. We all know brain doesn't understand anything except electrical impulse. Everywhere, whether it's a proprioceptive fiber, whether it's a smell, taste, everything is converted to electrical impulse, and then the brain appreciates. Now, in this case, the electrical impulse cannot be converted because the cochlea is damaged. In a normal cochlea, when the mechanical waves moves, the organ of Corti moves, and see the nerve is getting stimulated. I hope you can appreciate. Now, what happens in a child baby who's born with the hearing loss? He has a cochlea, he has a fluid, but there are no hair cells. So whatever sound is going, it's not stimulating the nerve. And we do a very simple task of putting an electrode in a cochlea so that cochlea, this electrode directly stimulates the nerve. Now, this cochlear implant has two parts. One part, which we do the surgery and put under the skin and put electrode in the cochlea, close the wound, and after 15 days, we put this processor which child wears. Now, this is a skin. This is a skin. We take an incision, put a receiver and an electrode in the cochlea. And once the wound heals, we put a processor and a mic. This transmitter is exactly sitting on a receiver. So with the radio frequency, the sound is transmitted. So this part is a transmitter, this part is receiver. They both sit over each other, only the skin is there underneath. To make you understand how the cochlear implant works, I think its video is not playing. Doesn't matter. In the end, if possible, I'll show you, but my video is not playing. Any idea how I can play? Anyone?
Pallavi.
Okay. Then, because a very nice video where I'll show you in the end. So then we give therapy and the child hears like they can hear and speak like a normal children. These are the two children born on the same day. One, nothing was done. He's deaf mute. School is attending. He's standing in 7th standard. He was invited in Jupiter where he gave an address. He addressed the gathering and he gave a speech, beautiful speech, but I don't think it's playing there. In the end, we will show you. But the question is, why so much hurry? Why are we rushing for so fast, trying to do the test and surgery so fast? This is just a representation. Obviously, it is not exactly the same. But remember, the brain has two parts. One is pre-programmed, that is hardwired, and one is the plasticity, where the synapses has to be developed. So there's an auditory area, there's a visual area, and there's a speech center. What happens in you and me when we are born? The sound enters the auditory area. Once the auditory area gets activated, what happens is the synapses are formed between the auditory area and the speech center, and the child starts speaking. Whatever he hears, it goes to speech center and we speak. But for some children, unfortunate children, this sound never enters the auditory area. So what happens? The auditory area is not active at all. So it's a nature's law. Use it or lose it. So what the next door visual area takes over the auditory area. Now, when the child is at 5 years, even if you do a cochlear implant, even if you give us some, is very difficult, and that's why we say that we should do it as soon as possible. It is like a race against the time. In developed countries, they detect the hearing loss at the age of 6 months. In our country, hearing loss is detected at the age of 3 to 4 years. That is sad, but with your help nowadays, with the pediatrician colleagues, we are getting children much earlier than what we used to get. We started this program in 2009. Till now, we have done 250 plus implant. First 100 we have done at Dr. Uppal ENT Hospital. I am thankful to Dr. Ram Gopal and Dr. Bhavish Bithia. They used to take care of the children. We used to just operate and leave there, and they were the one who were handling them. We have done lots. We feel happy when we talk to you. We feel, oh, we have done great. But when we are alone, we really feel sad. I don't think we have done justice. We are doing justice because if I do 10 implant, there are 90 still children in the society who are deaf and mute. And why are they? Either they come late because they are unaware, why either in the society or they don't have a testing facility, or there's a lack of finance. For finance, I remember, I don't know, some 7, 8 years back, as Honorable Municipal Commissioner and Honorable Mayor, we did the first cochlear implant with the help of Thane Municipal Corporation, Jaiswal Sahib and More sir, and they had said that we will give 2.5 lakh rupees to every child from anywhere in India. We did almost 100 implant with the help of TMC, but that was not adequate. Still 2.5 lakh was less. We need little more work. We were still missing a lot of patient, and I approached the commissioner and everything. They said, we will help you. And it was my luck. I shifted my practice to Jupiter Hospital, and trust me, the management has gone overboard to support me. This is a unique combination of the private-public partnership. The Jupiter Hospital CEO, Dr. Ankit Thakkar, Thane Municipal Commissioner, Shri Abhijit Ji, and myself, we discussed how best we can do for the society. And it was not a question of just giving money. We want to detect them early, and we started a universal infant hearing screening program. This is, please see, this is something phenomenal. I think the first corporation in the country we have done. The Thane has adopted all the government maternity homes and the medical college where the Jupiter Hospital ENT department with technician, they do the screening, find some problem, get them to Jupiter, do BERA, do all the tests, vaccination, radiology, CT, MRI, everything free done by Jupiter Hospital. Till now, we have done 8,000 screening, and we have done, we have detected 4 babies till now. We had operated one on now, next one more we are operating next week. And this is all thanks to Thane Municipal Corporation and Bangir Sahib. See, the fact is, they are ready to help you provided they get convinced that you are doing something good for society. End of the day, they have got the money. They are not giving from their pocket. It is the society money. It's our money. So once he got convinced, he went one step ahead. And this was something very, very different. That means hearing screening for every child born in Thane. Jupiter Hospital will do all the investigation and scans, including MRI free. TMC will pay for the cochlear implant. It's a big amount. They're paying 6.5 lakh rupees for every implant, and we will perform this surgery free. Charges will be, speech therapy will be given. And one most important thing which no one does, the second year implant. So you see, central government, state government, they give for 1 year, but they don't give for second year. Thane is the only city who does. So if you have a child who has done 1 year, Thane Corporation will be more than happy to support you with 4.5. We got a lot of recognition, a lot of, people appreciation. Of course, you do feel good when people recognize you. But the real happiness comes when your child whom we have operated, Ram Gopal and Bhavesh, will remember this child very well. We have done the surgery 9, and after getting 98%, whooping 98% in CBSE, she competed with the children, normal children, and she stood second in the class, and she came fantastic. And bigger fantastic icing on the cake. This year, just a month back, she got admission in IIT Bombay. Can you imagine what more we want in life than when people say medical profession is this, that? Okay, everywhere there are some negative things, but these kind of satisfaction, I almost had the same satisfaction when my both children got into IIT Bombay. Perhaps this happiness was little more. All children are doing well, a lot of children are doing well, and our job is not yet over. Just operating and doing a number is not enough. We train the doctors from all over India, and I thank Jupiter Hospital. They give me all the infrastructure, and nobody will believe that corporate hospital is doing. I'm not here to promote Jupiter Hospital, but telling from my heart, they have been out of the way, do what you want. And these are the candidates, they come from all over country. We give them a microscope, we give them a bone, we give them a cochlear implant, they do the practice, and we regularly train these surgeons. And of course, we all know when you teach, you learn, and I also learn from them. Friends, this is for all of us. In today's age and time, if a patient is deaf mute, and we all have to do some introspection, especially when the hearing testing is available, funds are available, infrastructure is available. Why should child be deaf mute? As a pediatrician, you have a primary role, you have more responsibility that no child should go undetected. Later on, you can direct message me if you want. I'll give my secretary's number. The patient can directly walk in like a VIP patient, and everything will be done free of charge. Thank you very much. And how much time I took? I think 30 minutes only. So next half we will speak. Now, any questions, or we will take later on? 1 minute.
Sir, questions we'll take at the end.
Yeah. Now, I'll just tell you, I'll just see, can you hear the sound? See?
Good morning, everyone.
Can you hear, Ramgopal?
Yes, sir. Yes, sir. We can hear.
I'm also one, born with birth defect. I was born with hearing loss. That means I would never hear and speak. Thanks to doctors like you, especially the Dr. Upal and his team.
I just wanted to show you that these children can be absolutely normal. And just give me a second. If it is there, I would like to show you working of cochlear implant. Very interesting it is. That's why I... Sorry. Ramgopal, your photo is here. So, okay, I'll keep your photo on the side. Will enlarge.
Sir, your screen sharing stop हुआ है.
Screen sharing नहीं हो रहा है?
नहीं.
Okay, फिर कैसे करूँ? जाने दो. Okay. I don't know how to do. Let's forget this. The time will be wasted. Anybody knows how to play this video on screen sharing?
Sir, kindly share the screen again. You will get the windows, different windows. Select your video and play it again.
Where are you now? Yeah, okay. I will
click on the share screen button, sir.
Yeah.
After that, you will get the different windows of your laptop. Yes. Yes.
Where is
now
that?
Just play your video, whatever you want to play.
1 minute. Where is that gone? Yeah. Now it's coming?
Yes, sir.
Yes, sir. It's coming.
So this is a sound. Instead of going in the ear, it's picked up by the mic. This is a chip. This is a heart. There's a mic. This is a computer here. This microphone picks up the sound, breaks down into different frequency. Each frequency is different stimulus. All 22 frequency, they go in, and this goes as electrical signal. This electrical signal by radio frequency is transmitted to transmitter, which we have already implanted. And from here, the wire goes in the cochlea, and it's again converted to sound. It's mind-blowing. When you think about it, it is something unimaginable how these things are happening. But fortunately, children are doing very well. And just for your information, we have done about 8 cases, adult, 70-year-old, 60-year-old. If they lose hearing, it can be done. Now, shall we go to the other talk?
Yes, sir.
Now how do I do? I'll stop sharing. And now, I go Ramgopal, 1 minute.
Yeah.
It's come?
No.
It's
Yes.
there now? Okay. Fine. Well, we'll now have a second part of the talk. Now, see, tonsils and adenoids, we are all aware about. When I was a student, you can hear now, please? Can you hear?
Yes, sir. We can hear you.
Okay. When I was student or resident, we used to have 4-5 tonsil surgery every day. Today, we don't even have 1 or 2 surgeries in a week. Reason is not that something grossly we have become better or anything. The point is that now the infection part, which we were worried initially, we are not worried. Good antibiotics and surgery is very, very less. We all know tonsils are in an oral cavity, and these are the adenoid at the back of the nose. Now, if you see inflammation, a white patch, it's usually a tonsillitis. Antibiotic, obviously, as a pediatrician, you know more than me. Our antibiotic of choice is amoxicillin clavulanic acid. But if it doesn't work, we do a throat swab, and depending on the throat swab, we give it. These are the rare cases. There's a case of diphtheria, which I have seen only 2 in my 30 years. But whenever you get a white patch, and if it is more extensive than what you anticipate, do the throat swab for diphtheria. Tongue tie is a little bit a debatable topic, whether to operate, not to operate, when to operate. My point is that tongue tie is not only essential for speech, even for swallowing. When the child sucks the nipple, they need a good amount of power, and for that, tongue tie release should be done. Generally, in our setup, we tell them to wait for 3-4 years. Once the child is a little bigger enough, for anesthesia point of view, we should release it. There are some children we see 12-year, 15-year, 18-year, they have tongue tie and they have no complaint. So it's a very subjective thing depending on the patient, pediatrician, and ENT, when to do, when not to release this tongue tie. Other common thing which we come across is epistaxis. The commonest cause is nose picking and crust, which is from this Little's area or Kesselbeck plexus. Now, what is that? There's a rich blood supply and arteries, which is coming from all the side, and nasal mucosa being, exposed to the environment. Once the dry crust come, then the bleeding can happen. It's also called as Little's area. Thank God these videos are playing. Now you see this, you see the crusting and dryness, and when they come to you, these are harmless bleeding. 99% it stops by itself. Maximum you can give some xylomethazolin pack or something and bleeding stops. These are the cases if child keeps picking the nose again and again, ultimately what happens, the granuloma is formed. So therefore, all these patients, we tell the patient to use some form of either liquid paraffin or neosporin ointment or oil, whatever you want, but to keep the area moist and supple so crusting won't form and the bleeding won't occur. Suppose bleeding occurs, then what is to be done? Easiest thing is just pinch the nose, put xylomethazolin pack, wait for a minute, and bleeding always stops. Antibiotic has no role. Decongestant drop or leaf bleeding is there. Saline drop is to dissolve the crust. Ointment is important. Ointment they should keep applying for a longer time. We give T-Bact or B-Bact and say, okay, just keep applying in the nose, even though bleeding is stopped, because the child is going to get this crusting again and again. Very rarely, there is a condition called as angiofibroma. It's seen only exclusively in the boys. It is a vascular tumor. One has to be careful. It is not so common, but just remember, if he's a boy, if he has a profuse bleeding, one should consider that if it is a vascular tumor called angiofibroma. In the girls, it is never seen. If bleeding stops by itself by pinching the nose, that means it is not angiofibroma, because angiofibroma is deep in the nasopharynx. Now, foreign body in the nose. Now you see, foreign body in the nose is very, very common thing. This is a missed foreign body on the right side, where the child forgets that there is a foreign body and they come quite late. And then there is a sort of called as a rhinolith. That means a stone formation because it was neglected and it was there. But if the child comes immediately, one can see the foreign body and easily remove it. As far as the ear is concerned, I told you there's no urgency, give the drop. You can also do the syringing, everything. But nose, has to be careful. Why careful? This is one of the pediatrician who tried to remove the foreign body from the nose. See, he removed, nothing came out. Why? Because the foreign body was in the other nostril. So you require a good illumination. Of course, you can try if you're sure, but there is a high chance that foreign body may slip inside. If you can't see the foreign body, put some nose drop, take a otoscope, look into that, you will see the foreign body, and then you can make an attempt to remove or send it to a nearby your colleague, an ENT surgeon. Ear foreign body is never an emergency, but nose foreign body, we get worried that child may aspirate and cause a problem. If you see, the nose and the eyes are separated by a very thin bone called lamina papyracea. If the child has sinusitis, if you are giving antibiotic, you are free to treat as long as you want to treat. But anytime if you feel redness of the eye or swelling around the eye, immediately you should be alert. Alert means not something great, but put on a higher antibiotic, put on intravenous antibiotic so that it doesn't become an orbital abscess. Now, this child was having a lot of cold for many, many days, was treated by his family physician. Redness came, but still they didn't bother and eventually developed an abscess. We have to drain it. Child became all right, luckily, but sometime they are not so lucky, and one can get cavernous sinus thrombosis because of this. You can treat the nose as long as you want if it is limited to the nose. The moment the inflammation is going beyond the nose, as a pediatrician, you should immediately refer to your colleague or put on IV antibiotic and take ENT opinion. This was a 25 days old baby and he had a huge abscess, and patient was very, very reluctant to do an external incision. We did internally and we removed, drained the abscess, and we are, what do you say, our name is in Limca Book of Record for doing the youngest baby. Well, not to say big thing about it, but then it can be done if on timely we see. Now we'll come to pediatric OSA. You see, why I'm showing you this thing is 1/7 the population of the world is having this OSA, and 50% of the patient have an etiology in childhood. If we neglect in childhood, eventually in adult, they have a very crowded teeth and a high arch palate, and they have a problem. You have to understand that there's a primary story. That means noisy breathing, no desaturation, no awakening. It's nothing to bother about. There is an OSA where there is a desaturation, respiratory distress is there, that is an urgent. And most of the patients, they fall in upper airway resistance syndrome. That means there is sleep disturbance, there is a repeated awakening, there is no apnea, no desaturation. These are the cases which are harming the child maximum. Because these patients have no problem. 1 minute, I'll take the pointer. I don't know how to take. Anyhow, so these are the harmless. These are the emergency. While these are the cases where you have to be aware. If there is no desaturation, but repeated awakening, sleep disturbance causes a lot of problem. Now, one thing you have to remember why this thing happens is there is a discrepancy between demand and supply of oxygen. Of course, if there's obesity, hormonal issue, that is a different thing. But sometimes there's a decreased supply because there's an obstruction in the form of tonsils and adenoid. Or rarely there can be dynamic collapse because of pharyngeal lumen. In fact, most of the children, it is both. When the tonsils and adenoids are big, negative pressure is created and the pharyngeal wall gets sucked. And that's why they have all this problem. Now, these are the patient, there are 4 types of phenotypes of pediatric OSA. Either they have huge adenoid tonsil, lingual tonsil, or they're obese, there's some craniofacial anomaly or neuromuscular disorder. We are going to mainly cover in this about lymphoid hypertrophy. You see, these are the children who have this snoring. They will have the huge tonsils. Because they keep their mouth open, they get crooked teeth, and this high arch palate leads to further crookedness of the teeth. Now, these are the symptoms which we all are aware about. You know more than me. Snoring and not breathing well, fragmented sleep is the most disturbing thing because we know that good REM sleep is needed for the child's brain. And because of all this thing, there is excessive sleepiness and fatigue and daytime headache. The long-term sequelae, we all know if the child is keeps snoring, there's a metabolic problem, there's a pulmonary hypertension, there's a reduced attention, hyperactivity, and of course, adenoid phases. These are not theoretical. Practically, we see in day-to-day life all these problems if we don't treat their mouth breathing. Evidence indicates that reduced pituitary growth hormone is there in individual with air obstruction. I feel bad, when I was in early stage of my practice, when somebody said, Doctor, my Mulana operation tonsil karun taka, or just give me a second. I think my battery is low. It may go, but I think 10 minutes it will take. Okay. They say, Doctor, माझ्या मुलाचे tonsil काढून टाका so that he will grow. And I used to laugh at that. If by removing tonsil, if height could have been increased, then every doctor's child would have been 6 feet tall. But no, I was wrong. That is true. If the child is snoring, if child is not getting a good REM sleep, growth hormone will not be released. It has been shown that there's a significant increase in height and weight once the tonsils and adenoids are removed. We as an ENT surgeon are guilty because we also did not know about it in the early stages. This is a case who had a pulmonary patient, had tonsil adenoid, were just avoiding surgery, and eventually we had to take to the Jupiter and do an emergency adenoid tonsil for her because she couldn't maintain the oxygenation. Upper airway resistance syndrome is exactly like ADHD type of finding will be there. Same excessive sleepiness, fatigue, morning headache, same in USA, they have a same finding. There's a clear link between the pediatric obstructive sleep apnea and ADHD. Now, whenever there is a suspicion of ADHD, should be screened for OSA before you label them ADHD, before you put them on psychoactive medication. If there's an adenoid and tonsil, one should be treated that before they go for any kind of medication for ADHD. Behavioral problem, we have seen plenty. The moment you clear their airway, they become much better. Now, the only sad part is if they wait, even if you do the surgery, the neurocognitive morbidity may be only partially reversible and a learning depth may develop in such cases. That means we should not wait for too long. If the child is snoring and disturbs sleep, one should get it corrected as soon as possible. Then there is a craniofacial jaw structure, crowding of teeth, high arch palate, and narrow. Why do they get high arch palate? You see, in normal condition, our thumb bangs on the hard palate. And when the thumb bangs on the hard palate, it pushes the hard palate and hard palate becomes flat. And hard palate becomes nice this way. Suppose child keeps his mouth open all the time, tongue is not hitting the hard palate, it will make the hard palate arch and then there'll be crowding of teeth. Dr. Ram Gopal? Hello? Somebody there?
Yes, sir.
Yes, sir.
Just give me a second. My battery is going down. I'll just quickly get a charger and put it on that.
Yes,
okay?
sir.
Give me a minute, please. I'm sorry, hear me? Can you hear me?
Sir,
Yeah, okay, sorry. I didn't realize it was free. Okay, now the important thing is, if you realize, you and me, tongue is a very strong muscle. When it hit against the palate, we get a nice, lovely jaw. But if the tongue is not hitting against the palate, the upper palate becomes narrow. When it gets narrow, the teeth doesn't have a place to get accommodated. And that's why we are having a crooked teeth. Now, this is a very late we came to know in life. Basically, it's very simple. Open the nose and close their mouth. It's very important in children, not only for cosmetic looks, but for their neural development, for their brain development, for their IQ. It's very important. The commonest thing in adenoids are there. They're enlarged. It's so easy. You can just either give the spray or decongestant. If it don't give more than 3 months. In 3 months, if they're not better, one should do an adenoidectomy. Now, this clearly recommend that adenotonsillectomy is the first line of treatment for children with sleep apnea. A lot of children, they feel very good once we clear their airways. The cosmetic look is different, but because they can't breathe, they get a disturbed sleep. The REM sleep is not there, and that's the reason they have a lots of problem. With or without tonsillectomy is the mainstay of treatment for OSA in children. Now, there's a very interesting thing. The parent used to ask, doctor, why remove the tonsil? Tonsils are the policeman. Today, we have got such a beautiful technology where we do not remove the complete tonsil. Could you see what is being done? A slicing of tonsil has been done. So 40% of tonsil will be still there in the tonsillar fossa, but only thing is it will not obliterate. It will not obliterate the oral cavity, and child will be able to breathe well. Similarly, nowadays the technology has improved. With this is called as a coblation. What does it does? It melts the tissue, so chances of bleeding are very less. Previously, we could never remove a partial tonsil. We have to, if you remember in a student, they said find a plane, go to the capsule and remove the whole tonsil to avoid bleeding. But today, with this is called as a coblation, where what we do is we almost slice the tonsil so that 40% of tonsil is there with the child, and rest we take it out. Similarly for adenoidectomy. Now, polysomnography, such children, even doing tonsillectomy become very difficult. In that case, the only thing is we have to give them a CPAP machine. Well, OSA treatment is journey. It's not that we can just remove and child is fine. It's a long-term treatment. I think, thank you very much. That was the last slide. I hope I've not exceeded the time. So if there is, thank you very much.
yeah, Anuradha madam, any question in the chat
Yes.
box you can take.
I don't see, sir.
Bhavesh,
How do I come?
So shall I stop
Tejara,
the
sir?
sharing?
you can stop.
Yes, sir. Yes, sir. Thank you. Yes,
Tejara,
sharing is stopped, sir, now.
Sir, Tejara, sir, are we taking any questions or should I
Yeah,
continue?
I'll ask one. No, sir, most of the common emergency in pediatric patient, we do epistaxis is the most commonly they come because and the parents are worried because they see the blood. So what should be the first thing we should do in the epistaxis?
I
And
fully
is there
agree.
any medical management, because then they do expect us to write some medicine?
Correct. As I've told you, I do agree the seeing a blood, parent gets panic. Now, in fact, patient comes with a big dupatta, see doctor, so much blood and all that. Easiest thing is just pitch the nose. As I told you, 95% of the cases are from Little's area. So you pitch the nose, put at the eyes, exactly for the clotting time, bleeding time, whatever taught to us for 5 minutes, bleeding will stop. Keep an ice. Now the question is, they expect some medicine. And the easiest way and the best medicine to be given is saline drops. and keep xylomethazoline drop next to you. Dip in xylomethazoline, put a cotton and pinch the nose. Frankly, what stops is the pressure and nothing else. And then we keep giving them some ointment on little finger. They should apply in the nose. Avoid using a bud or something. We have seen patient where cotton remains inside and the stick comes out. Tell them to wash your hand, put a little finger and apply. It's more of a counseling. You have to give them medicine, nasoclear. Don't give xylomethazoline too much. It will further cause dryness and crusting.
So it would be ointment, not the cream. Antibiotic ointment.
Frankly, I'm not too expert on it. We ENT people are only the surgeons. Fusidin ointment I'm using since 20 years. I don't even know which company makes or anything, but Neosporin and Fusidin, anything you apply in the nose, and it's more of a lubricant. Frankly speaking, the simple tube and ghee will do equally good job. But if you give धूप and this ghee, they will take the money back from you. बोले ये तो हमारे घर पे भी है.
Right, sir. Okay. Yes, Anuradha madam, any question?
Yes, sir. Okay. I don't see any questions in the chat box, sir.
Then you can.
Yeah, there is a misuse of decongestants. Is there any, like, would you like to share your thoughts on this, sir? Misuse of decongestants.
Correct. Forget about the patient. Even the doctors misuse it because we want instant relief. And decongestant gives fantastic relief. If nose is blocked, put the drop, child can breathe so well. So I always tell the patient ki it's very easy for us. This block is getting so much problem, they put it. Then we tell them you gradually taper it. First, like in the adult, if there's a 12-year-old boy, we tell them put a regular drop, then put a pediatric drop, then put a saline drop. And with the time, the child will be okay.
Okay.
There any
few questions.
yeah, there's a question on laryngo. Yeah. Laryngotracheal malacia.
Sir, unmute.
Some words on laryngomalacia.
Sir, unmute yourself. Sir, unmute. Uppal sir, you have to unmute. You are muted.
Okay. Fine. Yeah.
Laryngomalacia.
Sorry?
Your thoughts on that?
Yeah. Now, in 30 years of my career, unfortunately, I had to take in the OT and do something. Except for reassurance, nothing is to be done. Frankly, nobody knows why it happens. There's a soft cartilage, and with the time, they become all right. Now, maybe I'd come to major institute in the last 4 or 5 years. Before that, it was small nursing home. That's why I was not seeing all these cases, small babies with laryngomalacia. But in my experience, nothing should be done except for reassurance until unless, oxygen is going down. In that case, my colleague has done one procedure. I had never done it before. That is called epiglottopaxy. What happens? The epiglottis, this is a larynx, epiglottis sits on the mouth of the larynx and the baby can't breathe. So you take the epiglottis and stick it to the tongue. You make it to raw area, epiglottis sits on the next tongue, so the breathing becomes better. But I personally feel it's too invasive a procedure for something which we can wait and watch.
Is there any role of
so any investigations to be done, or any investigations to be done, or we just wait and watch in the newborn? Yes, sir, in the newborn period.
I tell you, they come with stridor. They don't come with laryngomalacia. They get some, they make some noise. So at least we should put a laryngoscope and see that there is no cyst, no congenital anomaly, no vocal cord palsy. Once we are sure that nothing to be done, you have to reassure the patient. That's all. Whatever calcium, whatever you are given, there is no documentary evidence that it really works. In fact, if I get a case of malacia, I send to pediatrician. I tell them no surgical intervention is required. Medical line of treatment will be done by the pediatrician.
Sir, your thoughts on intranasal steroid sprays? That's another question for you.
The nice saying, I forgot that good doctor is the one who amuses the patient till the disease take care by itself. So my point is, when we give spray for 6 months, 1 year, we really don't know the spray is working, or with the age, the space has become better and he's feeling good. So it's very difficult to say. What I do is I tell the patient to use a saline spray, and whenever there's little discomfort, you can take a steroid spray. See, we are not a scientist. We cannot comment on the efficacy and all that. We can just say from our experience. Our experience says that we should not abuse that. We give the patient handy. Whenever you have a problem, use for 3-4 days, but don't keep on using for months and years and years. Especially the xylomethazoline abuse, we have seen lots.
Lots of
But
mucosal damage.
Yeah, but then it is such an instant relief that it is not possible not to use. Means if I get a nose block, whatever I know, the first thing is I have to put a drop and open up the nose.
It's a very distressing feeling to feel choked up and not unable to breathe from nose.
So we should taper them. We should just explain them, okay, in a lot of suffocation you put it, but as soon as the child is better, don't put it, put saline drops.
Yeah.
Ear, one thing, if somebody slaps on the ear and they come to you, never give the ear drop. That you should remember one thing. If someone slaps and the patient child is brought to you, whether you can see the drum or no, whether you can see the perforation or no, but don't give ear drop. Because whatever the injury has happened is a sterile injury. And when you put the ear drop, whatever infection can travel from outer ear to inner ear.
Are there any post-cochlear implant surgery complications that are significant or need to be?
Of course, the complications are there. I'll tell you 1 or 2 practical my complication, and then I'll tell you. The main thing is that these congenital cases, this inner ear direct. Sorry, there is somebody talking. Okay, this congenital ear are in direct connection with the CSF. Normally in you and me, the CSF connection and our inner ear is like a hairline tube. But these children with the congenitally, their opening is 10 times bigger, like a matchstick. So what happens, the moment you open the cochlea, the CSF starts flowing. And this CSF leak is one of the dreaded complication. And second thing is infection. Touch wood, till today, we have not got any infection, but getting infected and the implant getting exposed is a real sad state, because patient has spent 6 lakh rupees, and if we cannot salvage, we have to throw it and put a new implant. And any more complication? One very interesting complication, if I can show, it'll be great. It was a facial twitching. We put an implant. The patient had an anomaly. So instead of stimulating the auditory nerve, along with the auditory nerve, it was stimulating a facial nerve. And every time you call her Neha, she says, and her face used to twitch. But fortunately, there are 22 electrodes. We knew that which 2 electrodes are stimulating a facial nerve. Later on, we switched off those 2 electrodes, and the child is doing well. Complications are there. It's not a straightforward surgery.
In good hands, it's a great surgery. It's a great rewarding surgery. So how do we treat external ear fungal infections?
Now, fungal infection is basically especially seen in a coastal area. In Mumbai, we see so many. The reason is because of moisture. And fungus like a grass, I tell the patient, I remove it, it's going to come back again. You remove it, it's going to come back again. So we do the microscopic suction and we apply the ointment so that whatever spores are there, these spores will, will be killed with an ointment. Antibiotic to prevent the secondary infection. Antifungal in children I had never given. In adult diabetic we had given. In children I had never given. The basic treatment is suction with a vacuum. You remove the fungus. Antifungal drop. One thing you remember. These are the children, they develop some kind of perforation because of fungus. And now when you give antifungal drop, the whole drop enter the drum and the child gets severe pain. So you have to be careful before giving a drop to be sure that there is no perforation in the eardrum.
Rak madam, may I ask one question?
Sure, sir. Please.
Sir, in some cases, in obstructive sleep apnea syndrome, with intranasal steroids, sometimes that stuttering and snorting decreases, and even the desaturation, which is not going below sometimes 80%, also decreases in 3 months. So, are we justified in continuing that? And second is, do you have any experience with lingual tonsillectomy to be done in these cases, OSS? Does it reduces the nasopharyngeal space with coblation method and all that?
Okay, very nice. Now, if I can, I'll show you the lingual tonsil and surgery and what we did. Your first question was, sorry, what was that? You asked me.
Intranasal steroids in 3 months, patient had partial improvement in OSS.
Now just try to understand. OSA means there is a block, obstruction. There is a mechanical block, and this mechanical block are lymphoid tissue. Lymphoid tissue are in the nasopharynx, that is adenoid, and in the tonsils. Now, suppose these tonsils were inflamed. You gave corticosteroid spray. This tonsil shrunk and the child started breathing well. Obviously, nothing to be done. Any case of OSA is always given a medical line of treatment from 3 to 6 months, including oral steroids. Including oral steroid, the whole aim is to shrink the lymphoid tissue. Nasal cavity is a fixed bony space. In that, there is a lymphoid tissue. What do we do by surgery? We remove the lymphoid tissue. What do we do with nasal spray or oral steroid? We shrink the lymphoid tissue and the child feels better. In fact, all the children who come for OSA, everyone is given a good trial of nasal corticosteroid for about 3 to 6 months. And we give oral steroid in acute cases. So if they are happy, nothing should be done. But suppose you give steroid spray, they are fine. And after 3 months, again, they start getting snoring. Now, question is when to operate or when not to operate. It all depends on the patient. We leave it to them. You've got 2 options. Keep using a spray till you can. Or if with the spray, child can sleep well. There's no disturbance in a sleep. There's no question of surgery because this adenoid tissue eventually will regress at the age of 14 years. A 13-year-old child who comes to me with the same problem, I'll say, wait, within a year, it may start regressing. But if 3-year-old child comes with a problem, I tell them eventually you will have to go for surgery sometime. And what was your second question? Sorry.
Experience about lingual tonsillectomy in OSS by coblation. When do you advise it actually?
Now, lingual tonsil, I'm not interested. I'm interested in snoring and disturbed sleep. If the child is getting a disturbed sleep and if the child is getting snoring, which is not getting treated with your nasal steroids and antibiotic and decongestant, then the lingual tonsil shaving has to be done with the coblation. If the child is feeling better, nothing to be done. We have seen a 70-year-old man with a big lingual tonsil. We tell them, "Arey, itna bada lingual." Bole, "Haan, sir, it is there since childhood." So if we don't have a complaint, we should not do it. Complaint is a mechanical block. And being a lymphoid tissue, they respond very well to corticosteroids. How long to give and all that as a pediatrician, you have to decide whether surgery is safe or steroid is safe.
Because even
There's
after
one question.
giving adenoidectomy or tonsilloidectomy, 37 to 67% people, children may have OSS symptoms persistent, will require CPAP. So it becomes a difficult, but still after the medical management, adenoidectomy is the treatment for that.
I don't know about the figures, but what you said is very correct. Ultimately, the OSA is it is a multiple issues are there. Tonsil adenoid is the one thing. Their jaw, their big tongue, there is a tongue falling, the epiglottis is there, the pharyngeal lumen is constricted. There are too many things. We are talking only what we can do easily. Because tonsil adenoid is easily. I don't talk about base tongue reduction because it's too big a surgery. Even by tonsil adenoid, if we can give them 60% cure, say snoring was too loud, it has become less. You used to get up too often, it became less. Still, I feel we are justified. Even out of 10 patients, the 7 can get relief. I'm still justified by tonsils and adenoid, but base tongue and all that, it's too major a surgery I would like to avoid. And sometime what happens, I'll tell you, when they keep doing mouth breathing, suppose a child is there and is mouth breathing all the time, what has happened? There's a high arch palate. And because of high arch palate, the palate goes up, the nasal cavity becomes small. Now, this is a nasal cavity. When palate goes up, upper ka compartments became small. So even after surgery, the nasal passage is not adequate. So it will take time for the maxilla to expand. And that's the reason sometimes results are not as rewarding as we expect. But nevertheless, surgery is always recommended when all the medical line of treatment have failed.
One more question, last question from my side, sir.
Sorry?
Last question from my side, sir. In whether we should really do these lateral X-rays, because clinical scoring correlates well with the nasal endoscopy. And do you also advise the sleep-induced nasal endoscopy? So should we do X-rays or not? Or we, after clinical scoring, if we feel that patient is not responding, better to go to ENT surgeon? And what about the inferior turbinate hypertrophy or blue turbinate as a surrogate marker for adenoiditis causing obstruction?
Okay. Really very nice question. But why I'm saying it's a nice question is this day in and day out, we face this thing. Now, once the adenoids are enlarged, why should you send to ENT surgeon? ENT surgeon cannot see the adenoid. He has to do endoscopy. But why do endoscopy? Do a plain X-ray. It's a documented. See, today patient comes to you, you do an X-ray, oh, big mass is there. Fair enough. You give whatever treatment you want to give. Give it for 3 months, 6 months, spray. Child is still doubtful. Repeat X-ray, compare the 2 X-rays. If it is better than before, show the patient is better than before. Let me try further. If it is same or if it is increased, then you say, Baba, no point in wasting time. You go for removal. Now the question is, even if we remove the adenoids, there are 20% chance that mouth breathing may not go. For that, there are 2 reasons. One is, according to me, they became habitual mouth breather for so long, it takes time for them to learn to breathe through nose. Previously, we used to say that maybe there's a partial removal, adenoid have been not removed completely, but today with the endoscope and coagulation, every surgeon does a very good job. In fact, all our patients, we tell them, we will do the surgery, the nose will open. Nowadays, what I have done is after surgery, we repeat X-ray after 3 months and show them. Because nowadays patients want documentary evidence. Yes, doctor, you have done a good job. And once I give them X-ray, I don't care after 6 years again if adenoid develops. Okay, it's not my fault. I have done my job. And one more question you had asked. Sorry. One was the adenoid.
Yeah, whether the inferior turbinate hypertrophy or blue turbinate a surrogate marker for, because X-ray does not correlate with clinical scoring. What nasal endoscopy really correlate, but you have elaborated it, elucidated it excellent. Because if I am suspecting gives nasal steroids, not responding, ENT surgeon is there to help us out. About this inferior turbinate rapid or blue turbinate.
I'll answer you now in a very practical way what we do. Every case of adenoid, we shrink the inferior turbinate. Every case of adenoid, when I go for surgery, we shrink. We may or may not charge the patient. There is a very good submucous diathermy. That means if this is a turbinate, we put a needle, it shrinks, so no mucosa is damaged. वो थोड़ा contract हो जाता है. So the child feels whether it is really needed is a question mark. But I have realized that whenever I shrink this thing also, my results are much better. Obviously, it will be better because I have created the nasal part.
More space.
See, nose is the tunnel. We are removing only one stone of an adenoid. Rest of the tunnel, we are not doing anything. And rest of the tunnel, if we shrink the turbinate, they feel great. Almost every patient of ours, when we do adenoidectomy, we shrink the inferior turbinate. Whether it is justified, whether it is right, wrong, do we have a double-blind study? I do not know. I explain the patient that I'm going to shrink it, and they are okay with it.
Yes.
What are the clear indications of not using eardrops? Contraindication or contraindications to using eardrops. What are the clear contraindications?
First of all, when the pain
are there any?
No, it's not a contraindication, but they are useless. Especially when the child is having pain in the ear, it's otitis media. That means the infection is there beyond the drum. What your drops will do? Your drop cannot go beyond the. So, painful ear, I tell all my colleagues when child comes with a pain in the ear, don't give drops. The reason is next day वो drum फूटने ही वाला है. ते puncture होणार आहे. What do they say? Dr. XYZ drop टाकले आणि पू यायला सुरू झाले. This is a standard patient statement. So because when they go to the doctor, it is severe pain. Severe pain means what? The drum is almost stretched. So whether you give drop or you don't give drop, it was going to rupture, but they blame it to your drops. So avoid drops. Sometimes, I'll just tell you when insect goes in the ear, I used to take a lecture and say, don't put a torch. If you put a torch, the insect will get scared and it will go further in with the light. One of the family physician told me, Doctor, torch nahi marla tar charge kasa घेणार? How do you start the patient if you are not going to put a torch? I said, okay, you don't put it behind, but these are the practical things which you have to learn. And the eardrops per se should not be given for all pain in the ear. And steroid eardrops especially should be up.
One last question now. How much one can use earphones before it causes problems? How safe is it to use earphone, what we see daily everywhere?
Now, on the record and off the record. On the record, you should not use for a long period of time. Off the record, if you have a good earphone, if you are using at a low level, it is not going to cause any problem. We have seen people, the problem is if you use the earphone and suddenly loud noise comes, it is not an earphone. The source of the sound is too close to your ear, which can create a problem. If you don't use a good quality of earphone, it may heat and cause a problem. Frankly speaking, I'm not a scientist to answer this, but usually I tell my patient very simple. 60% of the volume, 60 minutes a day, it is acceptable. Right or wrong, it's off the record. I tell the volume should be not more than 60% and it should not be more than 60 minutes a day.
Okay, that's I think very a great advice, I must say. Dr. Chejara sir.
Challenge.
Hello. Chejara sir. Should I conclude?
Yes, ma'am. Please go ahead.
Okay. Dr. Pradeep Uppal sir, it was a very interesting and insightful lecture. Wonderful takeaway messages. The tuning fork test was really simple, doable, and informative for fluid accumulation. And I think we have to be more open to the ventilating tube to avoid ear infections going into adulthood. Also, you have really put a very proper point of using otoscope, which seems like a simple test. And there is use of caution in ear bleed. Then the work on cochlear implants is really mind-blowing. And as you rightly said, that it's the emergency, which is a race against time for preventing deafness in adulthood. And it's a very, very, I mean, you have done a very great job of doing 8,000 screenings. And also, Thane is doing a great job, phenomenal work in this field in giving the joy of hearing to those born deaf, along with the guidance and pursuance by Dr. Uppal sir. So the takeaway from this lecture was no one should remain deaf mute, though he or she may be unfortunate enough to be born deaf. And the second half was very, very interesting. It was like a page turner, like now what's the next topic? It was really, really made very, very interesting and informative, like tonsillitis, tongue tie, epistaxis. The topics which we come across daily were dealt with and with great clarity in such a short time. So thank you, Dr. Uppal sir, for your very, very enlightening and interesting at the same time this today's lecture. I thank you on behalf of Maha IIP for this session, and I think we call it a good night. Over to you, Dr. Chezara sir, for closing words.
If you have any query, anything, you can.
Yeah, I think the questions are. Yeah. Thank you, sir. Thank you and good night. Hello.
Thank you, ma'am. Can I end the meeting now?
With Chezara sir's permission.